Welcome to Vein and Lymphatic University Grand Rounds. My name is Lowell Kabnick, and we'll be here every Wednesday at 12 New York time to tell you that we are going to essentially cover in 2 years all of vein and lymphatic disease. And it gives me great pleasure to introduce Tomasz Urbanek, who will be talking to us on Flebogrif. And then following that, discussants will be Kirsten Schick from Germany and Alejandro Gonzalez from Mexico. That being said, we also have Tobias Hirsch today with us as well, and I'm sure he will then ask some questions as well. So that being said, we have 30 minutes and off we go. Tomas, the floor is yours.
Thank you very much for the invitation, and thank you for giving me this opportunity to be the part of this wonderful educative project. And I think, and I'm sure that we can have a really nice discussion concerning the topic. The device which I would like and the technique which I would like to talk about is right now invented in many countries, however, not much known like laser ablation or radiofrequency. We all know the concept of mechanochemical ablation, and it's not just the spasm of the vein and administration of the sclerosing agent, but also some possible influence on the better drug penetration through the and into the vein wall, which at least in theory should give us the better efficacy. But there are also some other points which we can potentially discussed and see in this method, which give us the option and opportunity to find the space for this technology, because as we know right now, the best treatment for our patients is the patient-tailored treatment. So we should adapt our possibilities to the anatomy and pathology which we see. We have this in the guidelines. I'm talking right now about the mechanochemical ablation when a non-thermal, non-tumescent technique is preferred. And of course, there are some medical and also some anatomical indications when we will think about using something which would be non-thermal methods. Currently, two most known methods in the market, it's a Clarivane by Merit Medical. It's a rotational MOCA with a liquid sclerosing agent, and Flebogrif is another device which is coming from Poland. We use doing this procedure foam and a special design catheter to induce the spasm and also vein wall injury. There are some new projects coming, I think, that Professor Kabnik will tell us something about because some new options are on the horizon. But today we will try to answer, do we have the golden standard technique for mechanochemical ablation? Seems that not. We are not sure if we should use liquid and foam. What kind of mechanism of the vein wall injury do we prefer? What's concentration of sclerosing agent? And what should be speed of the ablation? I would like to show you and introduce some experience with Flebogrif catheter. This device is coming directly from Poland, from Warsaw. Our colleague, professor of vascular surgery, Peter Ciostek, was inventor of this device some years ago, and it's his initial series of the patient treated with the device, which at this moment was his original invention. Then, of course, this came to the market as commercially available with a CE-mark device. Right now is the name of Flebogrif. There is the special construction of the tip of the catheter with hooks, as you see, which you open, and during the pullback of the catheter, you make the irritation of the vein wall, spasm, and also injury. It's usually the injury of the endothelial layer and some part of the intimal layer. It's a 6 French all-in-one box system with all set prepared for doing the procedure. So you just need the patient dressing and sclerosing agent. How it works, the short diagram for those of you who are not familiar. It's over the wire system. You go to 2 centimeters below the saphenofemoral junction. You open the catheter. You inject the foam when pulling back and getting the vein spasm. Concerning the amount of foam, it's usually 1 cc of foam per 5 centimeter of the treated vein, and for large veins we use rather the stronger concentration. Short video on the procedure is probably one of the fastest venous procedure on the saphenous trunk ablation. So 6 French sheet, wire till the groin, then catheter. Catheter is very well visible. Of course, all we do are the ultrasound. You position the catheter 2 centimeter. It's a catheter, as you can see, very good visibility. 2 centimeter below the saphenofemoral junction. You open the hooks, fix this, and then you pull back the catheter, administering the foam at the same time. So it looks not very, very complex. Of course, some learning curve is needed. What is the advantage of this procedure for the operator? It's over the wire, so you can overcome many problems with this. It's a very stable system, good visibility of the catheter. In ultrasound, there is no mechanical rotation, so you have just the continuous pullback, which you are usually familiar with from the catheter-directed foam sclerotherapy or an tumescent technique. Of course, no tumescent anesthesia and fast procedure. And this what is also important doing this kind. I will show you the data of our study later. For long veins, you can use a really low amount of the foam for the vein ablation, mechanochemical ablation. So here you go with the wire, some steps of the procedure. Then you introduce the catheter on the right side. It's very well visible. Of course, this is the position where we come with the catheter, but you should pull this back 2 centimeter out of the junction to stay away from the femoral vein. The opening of the hooks is quite easy, but remember, you should not push the catheter. You just pull back the sheet, the catheter, like this, and this open the hooks. So do not go opposite. So always the opening is with the sheet withdrawal. And here is the catheter after opening, very well visible, and you stay 2 centimeters away from the saphenofemoral junction. And then regarding the administration, initially this can be something to learn because you have to look on the markers of the catheter, to administer the foam properly. You have the markers every 1 centimeter. And additional markers every 10 centimeter, and you should, of course, close the catheter before removal from the sheet. Some important tips and tricks, as in Clarivein device, sometimes this can be stacking of the vein wall to the catheter. It does not happen very often, but it's possible. Usually the patients start to report pain at this moment, and what you can do, you can close the catheter like this. You close the catheter. You move this catheter 1 or 2 centimeter below, and then you reopen this and you start the procedure again. So this is something which can overcome the patient complaints, if happens, of course. And pullback speed control is something which you have to be familiar with, looking for the markers 1 cc of foam per 5 centimeter of the vein treated. You can treat 60 or even 90 centimeter veins with this catheter. It's a very good option for the patient with some venous leg ulcer and distal puncture for the long axial reflux till the distal part of the cuff. If you want, you can go also retrograde, but then of course the puncture will be opposite side to the normal procedure. When I would not use Flebogrif for the big veins, according to the producer, this is from 4 to 12 millimeters as an indication, but we almost never treat very large veins. For me personally, the good size is from 4 to 10 millimeters. Very angulated vein course, like for all the method, this can be the problem. Remember that we have the very large distance between the cutting element, 27 millimeters, but for the large veins, as all sclerotherapy-based technique, it's probably not a good option. So I would not use for the veins like 15 or 20 millimeters. Even if you want to put the tumescent solution around, this will not work properly. And also for the patient where you want so-called crossectomy, so ablation till the level 0 femoral vein wall. This is not that technique. This leaves you always the stump like for the standard laser ablation or radiofrequency ablation with the distance at least 1.5 2 centimeter from the saphenofemoral junction. Post-thrombotic vein, it's also, I think, not a good vein for this kind of technique, because you will have the problem to get the proper vein spasm. Saphenous vein thrombosis, as for most of this method, it's not a good example. And of course, some options which can be difficult to treat. There are the patients with very superficial located vein. We want to avoid the fibrotic cord or hyperpigmentations. And remember that if you try to use this for very small veins, less than 4 millimeters, then due to the huge and significant vein spasm, your catheter can be stuck. That's why for very small veins, rather not a good option. Here are some examples what should not happen. It's hyperpigmentation if you treat very, very superficial located veins, like in some patients after sclerotherapy. You can give foam through the catheter lumen. You can give through the vascular access. You can have the separate puncture, or you can give the foam to the branches when you withdraw the catheter. So various options regarding foam administration. If we speak about this technology, a good option to treat patients with growing neovascularization and the saphenous trunk below, like these cases after previous surgical procedures. Here one example, Flebogrif inside, neovascularization in the groin, and then trunk of the vein, which is incompetent. So first, with the catheter, there is the foam administration to the neovascularization, and if you fulfill this neovascularization, then you start the ablation below. So it's one of the very good indications to use this technique. Previously, we had not so many studies available regarding this trial. Right now, some new studies are coming. I will focus just on one trial, which we perform, finishing this talk, which we perform in Poland on 200 patients. It's PolFleb study, 4 centers in Poland, 4 to 10 millimeters saphenous vein, 2 years follow-up. We use the 3% polydocanol foam in these patients, and this is probably one of the most important slides. Mean diameter of the vein was 7.2 or something around the 7 millimeters, and mean length of the treated vein was 44 centimeters, so very long veins treated. And for such a length of the vein, the mean volume of the foam was just less than 9 cc. So you can treat really entire length of the incompetent vein with a low amount of foam, which gives you also a lot of safety regarding your sclerotherapy treatment. Speaking about the results, initially, of course, like for all the methods, all the veins were occluded, but speaking about the MOCA, we are always, and mechanochemical ablation, we are always interested in longer term results. And if we look some data regarding the procedure, most of these patients with really low level of pain and fast return to the normal activities. But the people always ask what is the anatomical success and what are the complications. Primary safety endpoint of the study was serious adverse event within the 30 days, and we haven't seen such a procedure, such a serious adverse events. Some very few foam-related problems, but none of them serious. And as you saw, the amount of foam was usually less than 10 cc. And if we speak about the 3 months follow-up results, no reflux in saphenous vein, 95%. Of course, in some of the patient, partial segmental recanalization, mostly in the proximal part below the saphenofemoral junction, but in most of the cases without significant clinical significance. There are the 12 months results. Of course, usually in the mechanochemical ablation, we go down with the anatomical success, and this is 90% of the complete and partial saphenous vein occlusion with no reflux, and the same results are kept after 24 months. It's 89% of the saphenous vein without reflux. So to finish this talk, here is also clinical efficacy from the study, but I will not discuss this in details. Speaking about the non-rotational mechanochemical ablation by Flebogrif, it's of course alternative to the thermal tumescent method, not for large veins, but for some of the anatomies and clinical situation can be crucial. It's fast and comfortable procedure for the operator and patient. You can reduce the foam volume, which gives you the significant safety. And this what is also important, no special investment, because this comes in this one box, and at least in Europe comes with CE mark. It's available also out of the Europe. Thank you very much for your attention.
Thank you, Tomasz. Clear, concise, and to the point. I'm going to turn it over to Kirsten Schick. Comments, questions?
Yes, thank you very much for this detailed explanation. I'm still new to this field, and so I really appreciate the insights of Flebogrif. Thank you so much. I have a question. Are there any complications unique to Flebogrif that one should be particularly aware of if you are a user?
Concerning the procedure performance, initial proposal from the company was to go with the catheter to the saphenofemoral junction and then do the passage with the Flebogrif catheter to get the spasm, and then come back to the groin and then do the mechanochemical ablation. If you have the small veins, usually the second passage can be very difficult. That's why the current indication is just do this once without previous passage, because it's difficult sometimes to come back with the catheter up. Should be always performed on the wire. Don't try to go with the catheter without wire, because it's a very soft tip and you can finish with the catheter angulation. This what the patient can report during the procedure. In some of the patients, especially if you have superficial location of the veins, like you do the straight branch, which is out of the saphenous fascia, which is also possible. Some of these patients report the pain during the pullback. So first, you have to speak with the patient. Pullback should be not too fast. And if the patient reports the pain, try to do this, what I proposed. Close the catheter, go 1-2 centimeters below, and then reopen the catheter and go again. And sometimes, if you treat the small veins, you will be faced with the situation that even if you open the catheter, the vein is like 2 millimeters, you will be not able to open the catheter because it's very, very small. But you still can continue with the foam sclerotherapy using this kind of device like a catheter, because then the opening of the hooks will be not possible. All other complications are usually related to the foam. And of course, we should not go very deeply into the vein system. That's why control your device always where you are, like for all endovascular techniques.
Yeah, thank you. Could I ask a second question?
Yes, please.
Are there, you described already which size of a vein you would treat, but are there any particular patient profiles do you see Flebogrif as clearly superior to thermal or glue-based ablation techniques? Would you say there is a group of patients? What is special possible for this treatment?
I mean, this can be medical and non-medical indications, of course, concerning this. I think it's a very good method if you have the long axial reflux going, for example, to the level of the ankle. Of course, in many centers, laser or radiofrequency ablation will be chosen for doing the femoral part and then to see what happens down, but I mean, below the knee. But if you have the patients with advanced stages like C4, C5, C6, and axial reflux, and the vein which is not extremely large, I think it's a very good and convenient method to do this kind of ablation of the femoral and below the knee segment. So this for sure will be one group. Second group, which I see right now, and I see still more and more patients. In Poland, where I work, we have the reimbursement for just surgery, open surgery, regarding the national healthcare. So all the minimal invasive procedures have to be paid by the patients. We know that, for example, the patient with C5, C6, many of them cannot afford such a, let's say, private treatment with expensive technology. So taking into account the cost of the device and the procedures, for these people, this is the chance to be treated by minimal invasive procedures, especially if we speak about, patient with venous leg ulcer and HAH4 or even HAH3, but saphenous vein incompetence. So This is the group of patients which is using this kind of device more and more commonly, especially if we take the financial aspect of the procedure. Then, of course, yes.
Thomas, there is a question here from Anil Hingarani about where the device is able to be used at this point, what countries, and what is the cost of the device in Poland?
This device has CE mark, so it's available in whole Europe, many out of European countries, including South and Central America. Alejandro, you have this also in Mexico, as far I know. In recent European Venous Forum meeting, we had the presentation from Korea with a big series of the patients. So I think that in many countries, but this is rather the question to the company where this is sold. It's not registered in US up till now, as far I know. You have just the Clarivane, but it's probably the issue of the company to go this direction. Perhaps more studies are needed, but I cannot precisely answer the question when this will be available in United States. Concerning the cost, here is really it depends on where and who is selling this, because I know that in some countries, like for example, in South America, Mexico, this costs much more than in any of the European countries. I don't understand the mechanism, but this is usually related to the distributors. In
Tomas,
Poland,
we're going to
in
move on,
Poland,
Tomas, because there are many questions that are flying
okay,
through here.
okay,
And
okay.
I want to let Alejandro have a chance to ask you or comment, and then Tobias after that, and then
Okay.
me.
Okay.
And I will throw some questions as we go. So go
Those,
ahead,
those
Alejandro.
are a lot of questions. Well, thank you for the opportunity to be here. Now, Thomas, it is recommended for 10 or 12 millimeter veins, the double pass technique for trying to produce a better effect. What other techniques can you use to improve the results? Are you using, for example, tumescent in very large collaterals that are there? Or what can you do to improve the results of this?
This what is important during the procedure is the position of the patient on the table. So we always do this in a leg elevation. So after normal puncture and going with the catheter to the groin, I always put the leg in the elevation. Tumescent anesthesia, this is a little bit against the concept of the hooks, if you which you have on the tip of the catheter, because you want to have as much as circle possible. With the tumescent, you always and sometimes splash the vein, and this is not the circle. So I would not advise. I saw this in some Congress presentation, but I would not advise to use the tumescent anesthesia to get the better efficacy. We have no proof that this is really going. Concerning the post-procedure course, we usually advise compression like after normal sclerotherapy, but I am not sure that this gives us more benefits regarding the efficacy. For sure, there is a lower level of the pain compliance, which is in reality very low. But for me, the major issue is if I have large veins, I would go for 2 passes, and then like elevation with emptying vein as much as possible. I am not aware about any study about the vein irrigation.
Thank you, Alejandro. Any more?
I'm good. You have a lot of questions.
Okay, Tobias.
Tomasz, according to the American guidelines, there is no, they don't distinct between endovenous thermal and non-thermal techniques. So we have an advantage that mechanochemical ablation is not that that expensive as glue is. But what would you see the advantage between Flebogrif and the other comparable technique, Clarivane? In which case you would prefer Flebogrif if you would have both in your toolbox?
There is, of course, no head-to-head comparison. We still have to look for the results which we have. For me, the advantage of the and we need the long-term follow-up studies to answer this question. But this what for me is the advantage of using the Flebogrif is that we use foam. which for me is still more potent than the liquid agent. Second, in reality, with 10 cc of foam, the vast majority of the patients can be treated, which gives you quite high safety. And the third, it's for me much more simple procedure because you don't face with rotational mechanisms which you have to go through with a certain speed. You just focus on pullback and foam administration. So there is for me simple, and it's still much cheaper, at least in our country, than the other device.
So I'm gonna get it. I gotta squeeze in here to Tobias. There are questions that are popping up, but if you can keep it short, Tomasz, keep your answer short. Go ahead, Tobias. Go ahead.
There is no official recommendation which concentration to use. What are you using? 1% or 2% or 1.5%?
We are using 3% polydocanol.
3%?
3%. I mean, usually we use 2 or 3% polydocanol.
This is my question, Tomasz, to you. Very simple. Do you really even need a catheter if you're going to use 3% foam?
There are two answers for this question. If I use just the catheter and just injection, I would inject 3 times more foam than using this kind of technique. So usually if you have 40 centimeter of the vein, 40, 50 centimeter with the size of 1 centimeter, there will be almost 2 syringes of foam to be given. In this case, you really limit this at least half. Second, we have the results of the meta-analysis of the catheter directed foam sclerotherapy without MOCA. The results after 2 years, it's something like 60 to 80% occlusion rate. In the studies which I am aware about the Flebogrif, we are after 2 years at the level of 90% of the veins without reflux. So seems to be slightly better.
So there are a couple of questions here that I want to ask you. There was one about complications from Dr. Kaguruki concerning you're starting at 2 centimeters below the SFJ, and why are there any anticipated complications, and that's why you're doing it? And I think you mentioned that that you start 2 centimeters below, and I suspect that's because of thrombus propagation, right?
I can mention that in our study on 200 patients, we have one case of ARTE. I mean, the thrombus going into the femoral vein, but just 1 in 200. But I suppose that going with all this foam directly into the femoral vein could be very more difficult. So usually we start pullback and then we start injection. So after getting first 2-3 millimeters to get this spasm.
And that's the same thing with Clarivane. They started the mechanical rotation, and then they started injecting. How did you treat your art?
Excuse
You
me?
said you had 1 in 200. How did you treat it? Or did you treat it?
Excuse me, I did not understand your question. Sorry.
So you had a thrombus projection into the common.
Okay. So this one, yeah, okay. I just thought that this is another question. So we treat this with low molecular weight heparin for 2 weeks and then completely resolved. This was something like a hit between 2 and 3. So we put on heparin and this was completely resolved. Like a normal complication after foam sclerotherapy. Right now, we don't speak anymore about the EGIT. We speak about the ARTE, but the treatment in most of the cases, as we learn from you, is the same.
Last question on the block here. It says, how long does it take you to do a procedure to the knee or full length?
There is no special. I mean, there is no special difference between the time when you do the entire length of the saphenous vein or to the knee. The most, I mean, the longest part is to go with the catheter, position this properly open. And then the speed depends on this, what you see on your syringe and the catheter. So I think this is the
5 minutes, 7 minutes, 8 minutes, 10 minutes.
No, I mean, Lowell, if you
Nobody keeps track of it. I don't.
If you are experiencing this, I think the whole procedure can finish within 10 minutes.
Fine, thank you. I'd like to thank everybody that's been on here. Tomasz, thank you. Kirsten, Alejandro, Tobias. Next week, we are going to have Professor Davis, and he's going to be talking about superficial venous ablation and when to use where. So thank you very much, ladies and gentlemen, and have a good rest of your day.